This is going to be a whirlwind trip through ultrasound, and it's just going to give you a little bit of a basic kind of idea. How many of you guys have actually seen ultrasound in person? Almost all of you. That's great. So in radiology, we've got four main modalities. We've got X-rays, which includes CT. We've got MRI, ultrasound, and nuclear medicine. Ultrasound, the beauty of ultrasound is that it is there's no radiation. You can see things in real time, so it's a very dynamic evaluation, unlike CT or X-ray. And it has incredible spatial resolution. We can get a dozen frames per second. So if we want to look at, if we really want to look at perfusion issues or, and great tissue differentiation. So good for soft tissues. Good for a dynamic evaluation, no radiation. We use it a lot in pediatrics. We use it a lot in obstetrics because of the no radiation. And we use it to guide procedures. As a general radiologist, I'll do things that are image guided, that doesn't leave anything in the patient. So if I want to leave a catheter in, it needs to go to interventional radiology, but general radiologists like me can do simple procedures like thoracentesis, paracentesis, abscess drainages, things like that. So I wanted to give you an idea, and this may be, I apologize ahead of time if it is too basic for you, but just to get your mind oriented to know how ultrasound images are created, we're going to just briefly touch on this piezoelectric effect, which is kind of the foundation for ultrasound. Talk about ultrasound wave properties and how they interact with tissue. So the transducer is essentially our ultrasound camera. It's over on the left side. It is composed of a bunch of piezoelectric crystals, and these piezoelectric crystals are called that because they're able to convert electrical energy into a mechanical force. So electricity comes in through the cord and it generates a vibration. There's hundreds, if not thousands, of piezoelectric crystals in each transducer. So that's sort of one of the important parts of the ultrasound machine. The waves propagate through tissue, bounce back, and return to the transducer. And the crystals are able to convert them back into electricity. They go into the ultrasound machine, and an image is mapped. So velocity mapping is one of the core principles with ultrasound. It's an assumption that the wave of the sound wave of the ultrasound sound wave will propagate at a constant velocity within tissues. So the waves that are reflected earlier are mapped to closer structures. The waves that come back to the transducer later are mapped to deeper structures. The other thing that comes into play with ultrasound is the frequency of the transducer, so the frequency of the wave that's emitted. Lower frequencies will penetrate deeper structures and travel farther. Higher frequencies have greater spatial resolution, but tend to attenuate, and so they don't. They're not good for deeper structures. Higher frequencies also have a higher resolution because there are more waves per meter or per centimeter. And then the machine examines the amplitude of the returned waves, and that's essentially going to be the brightness of the ultrasound. So if you look at this image, you can see the probe, the standard orientation is the transducer is on the top of the image, basically, and shoots down. The waves that propagate through fluid, which are going to be black, do not get reflected back. And so that area, for the time required, will map to nothing, so it's black. Echoes that return from the fetus's skin surface and from bone are going to be mapped variably depending on the amplitude of the wave that's returned. So you can see bone, like this frontal calvarium, is very bright. The hard palate is so bright that it actually blocks all the sound waves behind it. So ultrasound, one of its limitations is it really can't go through dense bone. Loudness of so we've kind of touched on this. I think that's pretty much it for my intro slides. We're going to go to the lab, and then it'll get a little bit more real for you. Pelvic ultrasound, that's an ovary up on the side, higher resolution because you can see it's very close to the camera, which is always in the US, allocated to the top of the image field. The fluid in that ovary is essentially their follicles, so again, mapped to nothing. You can see the tissue differentiation below. That's a thyroid, transverse image of the thyroid. You can see the strap muscles anterior to it, the trachea in the center, and then other potential uses. We use it for musculoskeletal ultrasound. Up on the top with a white line around it is a supraspinatus tendon. So great for shoulder evaluations, super high spatial resolution, equivalent essentially to most MRI, if not better than some MRIs, for the tissues that we can see. Again, we can't see past bone, so we can usually evaluate part of the rotator cuff very well, particularly supraspinatus. And it's dynamic, so you can look for a rotator cuff impingement and tears, effusions, things like that. The bottom image is kind of the workhorse for diagnostic ultrasound. It's a liver and then a kidney. And the nice thing to mention, ultrasound, unlike CT and MRI where you have axial, coronal, extrinsic measurement or extrinsic planes, ultrasound is always oriented with respect to the organ that you are interrogating. So you basically move the transducer however you need to, and you'll see that in a minute, to get a long axis and a transverse axis. So kidneys will be, you'll hold it one way. For the gallbladder, you'll be holding it a different way. And that's it. I'm sure I had more that I was planning on saying, but I can't remember right now. So if you have any questions, we can talk about it on the live scan. I think we're going to go in batches there, and that's it. It's great for, like I said, guiding any procedures like vascular things as well. Okay.